Welcome. In this session, we'll be discussing about retinal artery occlusion. We have discussed about choroidal non-perfusion in session 22 of this section. We'll be discussing several types of retinal arterial occlusion: central retinal arterial occlusion, branch retinal arterial occlusion, cilioretinal arterial occlusion, combined central retinal vein occlusion with retinal arterial occlusion, and ophthalmic arterial occlusion. And among these, central retinal artery occlusion, combined CRVO with retinal artery occlusion, and ophthalmic artery occlusion are potentially blinding. We'll be also discussing about cottonwool spots and paracentral acute middle maculopathy in this session. Central retinal artery occlusion, or CRAO, is a devastating retinal vascular disorder with a very high risk of severe visual loss, and it occurs due to an occlusion in the central retinal artery within the optic nerve at or just proximal, that is behind the lamina cribrosa. The obstruction in the central retinal artery occurs usually due to a thrombus or an embolus, but infrequently many other conditions can lead to central retinal artery occlusion, which we'll also discuss in this session. Majority of CRAO are caused by in situ thrombus formation at the site of occlusion in the central retinal artery, and a minority or less than 40% of all CRAO are caused by an embolus. One-third of all CRAO are caused by an embolus originating from a source within the ipsilateral carotid artery, and less than 10% of all CRAO occur due to an embolus from a cardiac source. And among younger patients with embolic CRAO, a cardiac source is more common than a carotid artery source. This clinical photograph shows the typical appearance of central retinal artery occlusion with diffuse retinal whitening in the posterior pole with a central cherry red spot in the fovea. CRAO has been classified into non-arteritic and arteritic CRAO, with non-arteritic CRAO contributing to 95% of all CRAOs. Three types of non-arteritic CRAO has been described, with the isolated non-arteritic CRAO being the most common, as seen here in this clinical photograph. The other two types of non-arteritic CRAOs are non-arteritic CRAO with cilioretinal artery sparing, as seen here in this clinical photograph, and transient non-arteritic CRAO, which lasts minutes to hours only. Arteritic CRAO contributes to only 5% of all CRAOs, and arteritic CRAO can occur from inflammatory disorders, most commonly giant cell arteritis, and this is very important to remember. Arteritic CRAO can involve the choroidal and the optic nerve circulation also, as seen here in this clinical photograph, which shows severe optic disc pallor along with pallor of the retina. The annual incidence of CRAO is said to be 1 in 100,000 individuals in the general population, with males being more commonly affected than females. The mean age of onset of CRAO is around 60 years, but CRAO can occur in individuals within a wide age range. As we have mentioned, the most common cause of CRAO is in situ thrombus formation within the central retinal artery, usually due to atherosclerosis, and among embolic CRAOs, carotid artery atherosclerosis is the most common source of an embolus in patients in this age group. But as we have mentioned, embolic CRAO in younger patients usually arise from a cardiac source or a carotid dissection. So among the systemic risk factors and associations of atherosclerosis, either in the internal carotid artery, the aortic arch, the ophthalmic artery, or the central retinal artery are common, either causing in situ thrombosis within the central retinal artery or an embolus from an atheromatous plaque from any of these arteries. And these risk factors include hypertension, diabetes mellitus, hyperlipidemia, cigarette smoking, coronary artery disease, and cerebrovascular disease. Other sources of embolus which may cause central retinal artery occlusion include carotid dissection and cardiac valvular disease, which, as we have discussed, occur more commonly in younger patients, and myocardial infarction and left ventricular valve motion abnormalities. Other infrequent sources of emboli can be tumor emboli from cardiac myxoma or metastatic neoplasm, septic emboli due to septicemia or from endocarditis, fat embolus in long bone fractures or pancreatitis, as shown here in this clinical photograph, talc emboli in intravenous drug addicts, as seen here in this clinical photograph, fillers injected in the face for cosmetic purposes, Radiological contrast agents used for angiography, dislodged thrombus during carotid end arterectomy, and deep vein thrombosis. Systemic risk factors for CRDO also include coagulopathies, with this photograph showing a patient with thrombotic thrombocytopenic purpura, inflammatory diseases such as giant cell arteritis, systemic lupus erythematosus, as seen here in this clinical photograph, polyarteritis nodosa, and granulomatosis with polyangiitis, and infections such as zoster ophthalmicus and orbital mucormycosis. Ocular risk factors for CRDO include acutely elevated intraocular pressure, which can occur from retrobulbar hemorrhage, intravitreal injection, expansile gas injection within the eye, prolonged prone position with ocular compression during spinal surgery, and orbital emphysema, usually due to trauma. Retrobulbar injections can also directly injure the optic nerve and the central retinal artery within it, and anomalies such as prepapillary arterial loops, as seen here in this clinical photograph, and optic disc bruising can also be associated with central retinal arterial occlusion. Radiation therapy in and around the eye is also known to cause retinal arterial occlusion. CRDO characteristically presents with sudden onset painless severe loss of vision, and 75% of patients with CRDO have a visual acuity between counting fingers to light perception, but no light perception vision in central retinal arterial occlusion is infrequent, probably because of preserved oxygenation to the peripheral retina from the choroid. But no PL vision occurs in the arteritic form of CRDO and ophthalmic artery occlusion, in which the choroidal circulation can also become involved. But central vision may be normal in eyes with CRDO having foveal sparing by the cilioretinal artery. In 10% of all CRDO cases, the sudden onset visual loss of CRDO is preceded by transient visual obscurations lasting 2 to 30 minutes, and we have discussed about possible causes of transient visual obscurations in a separate session in the neuro-ophthalmology section. And transient visual obscurations occurring due to obstruction of blood flow in the retinal circulation is called amaurosis fugax. An occurrence of amaurosis fugax prior to onset of CRDO suggests an embolic cause of CRDO. Patients with amaurosis fugax describe it as a visual loss affecting total or partial visual field, which often appear as a curtain coming from one side in front of the eye. Though 10% of CRDO may be preceded by transient visual obscurations, only 1% of individuals with transient visual obscurations go on to develop CRDO. And among the other etiologies of transient visual obscurations, the symptoms of retinal migraine and migraine with order need to be differentiated from the symptoms of amaurosis fugax. Retinal migraine is characterized by stereotypic episodes of monoocular scotomas followed by onset of headache, which may occur several times in a day. And migraine with order has homonymous visual symptoms, typically appearing as scintillating scotomas. Recanalization of the site of occlusion in the central retinal artery typically occurs within 3 days after the onset of symptoms, and the length of time the central retinal artery remains occluded determines the final visual acuity. Partial improvement of vision, if any, occurs only in the first 7 days after the onset of symptoms, but not thereafter. And it has been seen that this partial improvement of vision occurs spontaneously in 1/5 of patients with non-arteritic CRDO, but less than 10% have any meaningful visual recovery. In acute stage of central retinal artery occlusion, relative afferent pupillary defect can be elicited, and the pupillary reaction to light being a mass response of the retina, RAPD is elicited regardless of foveal sparing by the cilioretinal artery. Rubeosis iridis or neovascularization of the iris is uncommon at presentation, but may rarely be seen in eyes with coexisting diseases which have risk factors in common with CRDO and cause chronic retinal ischemia such as diabetic retinopathy, ischemic CRVO, and ocular ischemic syndrome. We have discussed about diabetic retinopathy and ischemic CRVO in earlier sessions, and we'll be discussing ocular ischemic syndrome in the next. As we have mentioned earlier in this session, the two characteristic clinical signs of central retinal arterial occlusion, which can be detected on fundus examination, are retinal whitening or opacification and a cherry red spot. The retinal whitening or opacification occurs due to ischemic damage to the inner two-thirds of the retina, which is supplied by the retinal circulation. And this appearance of retinal whitening or opacification corresponds to intracellular edema and cessation of exoplasmic flow due to ischemia. The retinal whitening or opacification may take a few hours to appear clinically following the onset of symptoms. The retinal whitening or opacification is most prominent in the posterior pole, particularly in the perifoveal area where the ganglion cell layer and the retinal nerve fiber layer are the thickest. But this retinal whitening is much less prominent or is absent in the peripheral retina, and this is said to be because the ganglion cell and the retinal nerve fiber layers in the peripheral retina are thin, and even though the blood supply to these layers in the peripheral retina are interrupted in CRAO, the thin retina in these peripheral areas can be adequately supplied with oxygen diffusing from the choroid. The retinal whitening or opacification of CRAO resolves in 4 to 6 weeks, and this corresponds to loss of the damaged neurons and replacement with an acellular scar of the inner retinal layers. The cherry red spot sign in acute stage of CRAO is the appearance of the foveal center when the perifoveal retina becomes opacified, and this appearance of the foveal center occurs due to absence of the inner retinal layers from the outer plexiform layer to the retinal nerve fiber layer in the foveal center, and it is these inner retinal layers which become ischemic and pale in CRAO. So the absence of these inner retinal layers in the foveal center allows visualization of the normal RPE and the choroid through the normal outer retinal layer, that is the photoreceptor layer, which being supplied by the choroidal circulation remain intact in CRAO. It is important to note here that in ophthalmic artery occlusion, since the choroidal circulation is also affected, the cherry red spot sign is not so prominent, as we will see in a photograph subsequently in this session. And since the appearance of the cherry red spot sign at the foveal center is consequent to the opacification of the perifoveal retina, the cherry red spot sign becomes less prominent and disappears with time along with resolution of the perifoveal retinal opacification. This is a list of the differential diagnosis of the cherry red spot sign, and all of these are hereditary metabolic disorders, which we will be discussing in the session on hereditary vitreoretinopathies. In the acute phase of CRAO, the retinal arteries distal to the site of occlusion usually appears thin and attenuated, as seen here in this clinical photograph. And both retinal arteries and retinal veins can have segmentation, also called box carding or cattle tracking of the blood column, and this is due to sluggish flow of blood in the retinal arteries and veins distal to the occlusion in the central retinal artery, and this sluggish flow of blood results in separation of the blood serum from erythrocytes, leading to rouleau formation or a clumping of the erythrocytes. So we can see segmentation of the blood column both in the retinal artery and in the retinal vein in this clinical photograph, and more prominently in this clinical photograph. Splintered hemorrhages may appear on the disc, but more extensive hemorrhages suggest an alternative diagnosis, such as combined CRVO with retinal arterial occlusion. Emboli such as these may be seen within the retinal arteries during fundus examination in 20 to 40% of eyes with central retinal arterial occlusion. But these emboli seen on fundus examination of CRAO eyes are not the causative emboli for the CRAO, which lies in the central retinal artery behind the lamina cribrosa within the optic nerve. We'll be discussing the types and characteristics of emboli when we discuss branch retinal arterial occlusion, in which the causative emboli is seen on fundus examination at the bifurcation of retinal arteries. In non-arteritic CRAO, the optic disc typically appears normal and less frequently can be hyperemic or edematous, whereas in an arteritic CRAO, the optic disc appears severely pale because of the associated arteritic anterior ischemic optic neuropathy. And it is very important to understand that the arteritic process, which involves the central retinal artery, can also involve the posterior ciliary circulation supplying the optic nerve and the cilioretinal artery, as well as the ophthalmic artery. As with neovascularization of the iris, neovascularization of the optic disc is rarely seen in the acute phase of central retinal arterial occlusion, but may be seen in eyes with coexisting diseases such as diabetic retinopathy, ischemic CRVO, and ocular ischemic syndrome. As we have mentioned, 15% of all CRDO eyes demonstrate foveal sparing by the cilioretinal artery. A cilioretinal artery is found in one-third of normal individuals and originates from the posterior ciliary circulation and not the central retinal artery, appears on the temporal aspect of the disc and supplies the papillomacular bundle or a portion thereof. In CRDO patients with foveal sparing by the cilioretinal artery, the retinal area supplied by the cilioretinal artery appears normal and is surrounded by pale ischemic retina from which it is well demarcated. In these patients, visual acuity depends on the portion of the papillomacular bundle supplied by the cilioretinal artery, and these patients usually complain of preserved central vision with surrounding visual field defect. And even if a cilioretinal artery is present in an eye with arteritic CRDO, foveal sparing by the cilioretinal artery does not occur in these eyes, as the cilioretinal artery is likely to be involved in the arteritic process and thus also becomes occluded in addition to the occlusion of the central retinal artery. Several days to weeks after the onset of CRDO, the retinal whitening and cherry-red spot disappear as we have discussed. The disc appears pale as seen here in this color photograph, and the arteries appear narrowed and sheathed. Nettle-shaped cilioretinal collaterals may be seen around the optic disc in 20% of CRDO in the chronic stage, and these represent connections between superficial retinal arterial and deeper ciliary arterial circulations. Macular RPE changes are less common in central retinal artery occlusion as compared to ophthalmic artery occlusion, because unlike in ophthalmic artery occlusion, the choroid is spared in central retinal artery occlusion, and gliosis such as epiretinal membrane formation does not usually occur following central retinal arterial occlusion, because the glial cells are also destroyed by the ischemia induced by CRDO. Ocular neovascularization does occur in the chronic stage of CRDO and usually occurs within 5 months from onset of CRDO, during which patients need to be closely followed up. Neovascularization of the iris develops in up to 20% of eyes with CRDO, but neovascularization of the disc and retina is less common in CRDO. So this is similar to central retinal vein occlusion, where also neovascularization of the iris is more common than neovascularization of the disc and the retina. In a patient with a recent onset of CRDO of less than 7 days duration, monitoring and management for cerebrovascular and cardiovascular diseases take precedence over ocular diagnostic evaluations and should be urgently initiated in a stroke unit because of increased risk of mortality and morbidity from these causes in the period soon after the onset of CRDO. In the acute stage of CRDO, fluorescent angiography characteristically shows delayed filling of the retinal arteries, and a leading edge of the dye can characteristically be detected in the retinal arteries. Complete blockage of central retinal artery is very rare, so the dye does appear, albeit slowly, in the branches of the central retinal artery distal to the occlusion site in the central retinal artery. And in case of cilioretinal artery sparing, the filling of the cilioretinal artery as seen here in this angiogram is seen to occur much earlier than the branches of the blocked central retinal artery. Here we see a photograph of another eye with CRDO with cilioretinal artery sparing, and in the fluorescent angiogram of the eye we see filling of the cilioretinal artery followed by filling of the retinal veins prior to the branches of the central retinal artery start to fill. And because of delayed arterial filling and the sluggish flow of blood, arteriovenous transit time, or the time required by the dye to reach the retinal veins, is further delayed. Delayed filling of choroidal circulation as seen here in this angiogram, and delayed filling of the cilioretinal circulation associated with a CRDO indicates ophthalmic artery occlusion if the choroidal non-perfusion areas are generalized, or suggests the possibility of giant cell arteritis if the choroidal non-perfusion areas are more localized, and if giant cell arteritis is suspected, it requires immediate treatment to save the vision of the fellow eye. Following recanalization of the central retinal artery, there is re-establishment of blood flow in the retinal arterial system, and fluorescent angiography study of the retinal circulation at this stage may appear to be normal, although the visual loss persists because of infarction of the retina. In the acute stage of a complete or more severe CRAO, there is thickening and intense hyperreflectivity of the inner and middle retinal layers as seen here in this OCT image, and this is because of ischemia and infarction of the retina due to obstruction of blood flow both in the superficial and the deep retinal capillary plexus. The outer retinal layers appear hyporeflective as seen here in this OCT image because of the shadowing effect of the hyperreflective inner retinal layers, and this hyporeflectivity may be misinterpreted as subretinal fluid, and because of the absence of the inner retinal layers and their shadowing effect in the foveal region, the outer retina in this layer appear more reflective as compared to the portion of the outer retinal layer outside this region. Intraretinal and subretinal fluid is uncommon in CRAO, and the normal contour of macular fovea is retained as we see here in this OCT image. In incomplete or less severe central retinal artery occlusion, paracentral acute middle maculopathy or PAMM may be detected, which appears as hyperreflectivity of only the middle layer of the retina as seen here in this OCT image, sparing the inner and the outer retinal layers due to ischemia and infarction of the inner nuclear layer resulting from reduced blood flow to the deep retinal capillary plexus. And in eyes with PAMM, end-phase OCT shows these areas mostly in perivenous locations, the perivenous locations being the farthest from the arteries. In the chronic stage, OCT shows thinning of the inner and the middle retinal layers, which become infarcted in retinal artery occlusion, while the outer retinal layers appear intact, as seen in this 2 OCT image, with this image showing thinning of both the inner and the middle retinal layers following a more severe CRAO, and this image showing thinning of only the middle retinal layer following PAM due to incomplete CRAO. And months to years following CRAO, these signs indicate a previous episode of CRAO. OCTA shows decreased flow and capillary dropout in the deep and superficial retinal capillary plexus, and the OCTA image corresponding to this fundus image showing CRAO with cilioretinal artery sparing shows intact capillaries in the cilioretinal circulation with capillary dropout in the remainder of the retina. In the acute stage, fundus autofluorescence shows hypoautofluorescence in the affected area, and this hypoautofluorescence disappears within a month with thinning of the affected layers of the retina. Calcium-containing emboli appear hyperautofluorescent and may be more easily detected by this method than by clinical examination. Visual field examination in an eye with CRAO typically shows central scotoma if cilioretinal artery is not present in that eye, and in eyes with severe CRAO, there may only be a remaining temporal island of vision. If the fovea is paired by a cilioretinal artery, a central island of vision appears relatively intact with peripheral visual field constriction. Dark adapted ERG with a bright flash stimulus typically shows a negative waveform. This is because the negative A waves are intact as photoreceptors are not affected in CRAO, but the positive B waves are severely attenuated as the bipolar cells become infarcted. And if the negative A waves are also absent on ERG, ophthalmic artery occlusion should be suspected. Doppler ultrasonography of retrobulbar circulation in CRAO can show reduction of blood flow and presence of thrombus or embolus in the central retinal artery, while blood flow remains normal in the ophthalmic and the ciliary arteries. And this method can differentiate central retinal artery occlusion from ophthalmic artery occlusion. As we have mentioned, patients with recent onset CRAO should be monitored in a stroke unit, and the systemic workup should ideally be carried out when the patient is admitted there. And as we have discussed, an embolic source can be found in less than 40% of patients with CRAO, suggesting that thrombus formation in the central retinal artery is a more common cause of CRAO. Giant cell artery should be ruled out in a patient with CRAO, particularly if the patient is an elderly individual with signs of choroidal ischemia on FA, signs of arteritic AION, or having systemic signs of giant cell arteritis, and this is very important to remember. The laboratory tests which can help us to rule out GCA with a high degree of sensitivity are erythrocyte sedimentation rate, C-reactive protein, and platelet count. And if giant cell arteritis is suspected based on these tests, immediate institution of steroid therapy is mandatory to save the fellow eye, followed later by biopsy or Doppler imaging of the temporal artery to confirm the diagnosis of giant cell arteritis. Detecting plaques are more important than assessing stenosis on carotid Doppler ultrasonography in patients with central retinal arterial occlusion, whereas assessing stenosis is more important in patients presenting with ocular ischemic syndrome. It is important to remember that carotid Doppler ultrasonography cannot image the intracranial portion of the carotid artery and the intrathoracic portion of the aortic arch, and so CT or MR angiography has a higher diagnostic yield in this situation. This carotid angiogram shows a plaque in the internal carotid artery. Echocardiography is particularly important in younger patients with CRAO and in those with calcific retinal emboli. Diffuse weighted magnetic resonance imaging of the brain is recommended to detect cerebral infarcts. An ECG with Holter monitoring is also suggested to detect cardiac arrhythmias, which can be sources of emboli. Evaluation of hypercoagulable disorders is indicated in younger patients with no known source of an embolus or with a family or personal history suggestive of thromboembolism. As we have mentioned, patients with a recent onset CRAO and also those with transient visual obscurations are at a high risk of cerebrovascular attack soon after the onset of a CRAO, and these patients should be referred to a stroke unit for observation and management along with screening for giant cell arteritis. Patients with predisposing conditions such as atrial fibrillation, carotid artery dissection, and hypercoagulable conditions require anticoagulation, and treatment of any other etiology if detected should also be instituted. As we have discussed, on suspicion or evidence of arteritic CRAO, high-dose intravenous corticosteroid therapy should be immediately instituted to save the fellow eye, and this is very important to remember. And the high-dose intravenous corticosteroid therapy should be followed by maintenance with oral steroids or with tocilizumab, which is considered to be a steroid-sparing agent in this situation. There is no evidence-based therapy for non-arteritic CRAO, but certain interventions are performed based on anecdotal reports. Any attempt to rescue the ischemic retina should be carried out as early as possible, and consideration of treatment beyond 24 hours of onset is futile. Suggested therapeutic modalities for non-arteritic CRAO include attempt to dislodge the embolus by reducing the intraocular pressure, and this includes digital ocular massage by compressing the globe for 10 to 15 seconds and then suddenly releasing the pressure, and anterior chamber paracentesis. Attempt can be made to increase blood flow to the ischemic retina by vasodilators such as pentoxifylline and or by reducing blood viscosity with the help of isovolemic hemodilution, in which 500 ml of patient's blood is extracted and replaced with similar volume of hydroxyethyl starch. Carbogen, that is 95% oxygen and 5% carbon dioxide, and hyperbaric oxygen helps in increasing oxygen supply and also induces vasodilatation. Nd:YAG laser disruption of embolus or embolysis has also been described, and the Nd:YAG laser can be used either to fragment and dislodge the embolus distally or to dislodge the embolus into the vitreous cavity. Tissue plasminogen activated or TPA injection has been employed to rescue ischemic retina following CRAO, but the EAGLE study showed no significant difference in visual acuity gains between intraarterial TPA and conventional methods just described. But both groups, intraarterial TPA and conventional methods, had clinically significant visual acuity improvement, and so either or both can be instituted as early as possible following onset of CRAO. Tissue plasminogen activated is known to increase the risk of cerebrovascular hemorrhage, and American Heart Association recommends intravenous TPA within 4.5 hours of onset of CRAO in patients without systemic contraindications to intravenous TPA, and intraarterial or selective ophthalmic artery infusion of TPA within 6 hours of onset of CRAO in patients with systemic contraindications to intravenous TPA. And in patients with ocular neovascularization following CRAO, panretinal photocoagulation with or without anti-VEGF injection should be administered to prevent the development of neovascular glaucoma. Branch retinal artery occlusion or BRAO accounts for 38% of all retinal artery occlusions and occurs due to occlusion at the bifurcation of a retinal artery distal to the lamina cribrosa. Unlike central retinal artery occlusion, which is most commonly caused by an in situ thrombus formation, two-thirds or a majority of all BRAO occurs due to an embolus. Like central retinal artery occlusion, mean age of presentation of BRAO is 60 years and the male to female ratio is 2:1. But in younger patients, BRAO is more common than CRAO and does not have any sex predilection. Risk factors of BRVO and the systemic workup to detect them are similar as for central retinal artery occlusion, except that BRAO rarely occurs from giant cell arteritis. BRAO can occur in several ocular inflammatory conditions, both non-infectious such as Behçet, Kawasaki and sarcoidosis, and infectious such as toxoplasmosis and syphilis. BRAO has also been associated with the use of oral contraceptives, and recurrent bilateral BRAO in a patient, particularly a young female with vestibulo-auditory symptoms, suggests Suzak syndrome and should undergo MRI brain to rule out corpus callosum infarcts which are found in Suzak syndrome. Suzak syndrome, being an autoimmune disorder, requires immunosuppressive therapy. This red-free photograph shows a patient with Suzak syndrome having multiple branch retinal artery occlusion, and these are the middle and the late frames of fluorescent angiogram of this patient showing periarterial sheathing at the site of the occlusions. This is a fluorescent angiogram of another patient with Suzak syndrome showing periarterial sheathing on either side of the artery, and this is called the zebra sign of Suzak syndrome. Patients with BRAO typically presents with a sudden onset painless sectoral field loss, and the initial and final visual acuities are better than 20/40 in more than 75% of patients, and because of this, treatment is not recommended in the majority of BRAO patients. In 1/4 of BRAO patients, the sudden onset painless sectoral field loss can be preceded by amaurosis fugax. On examination, relative afferent pupillary defect can be detected in eyes with BRAO depending on extent of retinal destruction. In the acute stage of BRAO, opacification of a sector of retina will be found along the distribution of the obstructed branch retinal artery, and the opacification is maximum in the central portion of this affected sector as compared to its peripheral portion. In 60% of eyes with BRAO, the causative embolus can be detected at a bifurcation of the retinal arterial system as seen here in this clinical photograph, and few flame-shaped hemorrhages may be found on the margins of the affected sector of retina. The most common types of emboli which we come across in eyes with retinal artery occlusion are cholesterol emboli, platelet fibrin emboli, and calcific emboli. Cholesterol emboli, also called Hollenhorst plaque as seen here in this clinical photograph, appear yellow-orange in color, globular or rectangular in shape, and refractile. They originate from atheromatous plaques, most commonly in the internal carotid artery, and less commonly from atheromatous plaques in the aortic arch, ophthalmic artery, and in the portion of the central retinal artery further posterior within the optic nerve. Cholesterol emboli are typically small and usually do not cause complete interruption of blood flow. They may migrate distally and disappear over time. Platelet fibrin emboli, as seen here in this clinical photograph, appear as an elongated dull grayish-white column in the lumen of the retinal arteries. Like cholesterol emboli, platelet fibrin emboli also originate from atheromatous plaques, most commonly in the internal carotid artery and less commonly from atheromatous plaques in the aortic arch, ophthalmic artery, or the proximal portion of the central retinal artery. Platelet fibrin emboli are considerably mobile and can be seen to change in position or break up into fragments and frequently degrade soon after detection. And because of this mobility, they are more commonly associated with transient visual obscurations. Calcific emboli, as seen here in this clinical photograph, appear larger, white in color, and non-refractile. They usually originate from cardiac valves, and this is important to remember. Being larger in size, they occlude a more proximal segment of the retinal arterial system and cause more severe degree of occlusion. Emboli may also be an asymptomatic finding during routine fundus examination, but symptomatic emboli particularly those associated with transient visual obscurations, are associated with an increased incidence of cerebrovascular and cardiovascular morbidity and mortality. Several weeks to months after the onset of BRAO, the affected artery appears attenuated. There is localized sheathing of the affected artery at the site of obstruction. Artery to artery collaterals may be found on the retina, and they are said to be pathognomonic of BRAO. And although rare, neovascularization of the retina may be found, but neovascularization of the iris does not occur, and this is similar to BRVO, in which neovascularization of the retina is also more common than neovascularization of the iris. In acute stage of BRAO, fluorescein angiography shows delayed filling of the affected retinal artery distal to the site of obstruction. Filling of adjacent veins is also much delayed or absent. OCT shows thickening and hyperreflectivity of the middle and inner retinal layers, or only the middle layer of the retina in the affected sector, as seen here in these OCT images. This OCT image shows hyperreflectivity of both the middle and the inner retinal layers, and this OCT image shows hyperreflectivity of only the middle retinal layer corresponding to the inner nuclear layer. In a vertical scan OCT in an eye with BRAO, the portion of the retina only on one side of the fovea appears to be involved, and this corresponds to the anatomy of the retinal arterial system. Visual field testing in an eye with BRAO may show sectoral defects, central scotoma, or central altitudinal defect. In the chronic stage, fluorescein angiography may show normal retinal circulation, but OCT shows thinning of either the middle and inner retinal layers seen here in this OCT image, or only the middle layer of the retina in the affected sector. We may note here that the outer layer of the retina is preserved, and in the vertical scan of the OCT, the retina on only one side of the fovea is involved, while the retina on the other side remains normal in appearance. As we have discussed, because of excellent visual outcome in the majority of cases, and because of very low risk of neovascularization, ocular treatment is not recommended in the majority of patients with BRAO unless fovea is significantly involved. But like CRAO, urgent referral to a stroke center for detecting and managing cerebrovascular and cardiovascular events is strongly recommended. Treatment of any other etiology, if detected, should also be instituted. Cilioretinal artery occlusion, or CLRAO, accounts for 5% of all retinal artery occlusions. The cilioretinal artery arises from short posterior ciliary arteries instead of the central retinal artery, enters the retina from the temporal edge of the optic disc, and supplies the papillomacular bundle or a portion thereof. Cilioretinal artery is found in approximately 1/3 of normal individuals, and on fluorescein angiography, a normal cilioretinal artery fills simultaneously with the choroidal circulation 1 to 3 seconds prior to normal filling of the retinal arteries. Because the cilioretinal artery has a low perfusion pressure, typical risk factors of isolated non-arteritic CLRAO include nocturnal hypotension and use of vasodilator therapy such as antihypertensives and sildenafil. We may note here that these risk factors are also risk factors of non-arteritic acute ischemic optic neuropathy, because the optic nerve is also supplied by the low pressure ciliary circulation. Three types of cilioretinal artery occlusion, or CLRAO, have been described: isolated CLRAO, CLRAO associated with central retinal vein occlusion, and CLRAO associated with acute ischemic optic neuropathy. Isolated CLRAO, as seen here in this clinical photograph, accounts for 45% of all CLRAOs, and as we have mentioned, the typical risk factors of isolated CLRAO include nocturnal hypotension and the use of vasodilator therapy such as antihypertensives and sildenafil. Isolated CLRAO can also occur from vasculitis, but vasculitis such as giant cell arteritis usually causes CLRAO associated with arteritic acute ischemic optic neuropathy, and more than 90% of isolated CLRAO regain 20/40 or better final visual acuity. CLRAO associated with central retinal vein occlusion, as seen here in this red-free photograph and in this fluorescein angiogram, accounts for 40% of all CLRAOs. On the other hand, only 5% of eyes with CRVO have an associated CLRDO also. The CLRDO associated with the CRVO is said to occur because low perfusion pressure of the cilioretinal circulation cannot overcome the increased venous pressure of central retinal vein occlusion, and the prognosis of CLRDO associated with CRVO is more guarded than isolated CLRDO, with 70% regaining 20/40 or better final visual acuity. The visual prognosis in an eye with CLRDO associated with CRVO depends on the type of the associated CRVO, either ischemic or non-ischemic. CLRDO associated with acute ischemic optic neuropathy, as seen in this red-free photograph and in this fluorescent angiogram, accounts for only 15% of all CLRDOs. CLRDO occurs in an eye with acute ischemic optic neuropathy because both the optic and the cilioretinal circulations receive blood supply from a common source, the posterior ciliary arteries. CLRDO can be associated with both arteritic and non-arteritic acute ischemic optic neuropathy, and visual prognosis depends on the type of the associated acute ischemic optic neuropathy, whether arteritic or non-arteritic. Cilioretinal artery occlusion associated with arteritic acute ischemic optic neuropathy has a very poor visual prognosis. This color photograph shows a patient with cilioretinal artery occlusion associated with arteritic acute ischemic optic neuropathy, showing pallid edema of the optic nerve head. Visual loss is usually mild in isolated cilioretinal artery occlusion, presumably because the intact superior and inferior arcuate fibers supply some portion of the fovea, but visual loss in the other two types of CLRDO is moderate to very severe depending on the severity of the associated disease entity, central retinal vein occlusion or acute ischemic optic neuropathy. In CLRDO, whitening of an wedge-shaped, as seen here in this color photograph, is detected in the retinal area supplied by the cilioretinal artery. Additional features depend on the associated disease. Retinal hemorrhages and dilated and tortuous retinal veins is found in all four quadrants of the retina in eyes having CLRDO associated with CRVO. In eyes with CLRDO associated with non-arteritic acute ischemic optic neuropathy, the optic disc appears edematous and hyperemic, and in eyes with cilioretinal artery occlusion associated with arteritic acute ischemic optic neuropathy, the optic disc appears edematous and pale. In the acute stage of isolated CLRDO, fluorescent angiography shows non-perfusion of the retinal capillaries in the sector supplied by the occluded cilioretinal artery, as seen here in this fluorescent angiogram corresponding to this color photograph. We may note here that a cherry red spot may also be found in cilioretinal artery occlusion if the cilioretinal artery supplies a large portion of the macula surrounding the fovea. And in CLRDO associated with arteritic AION, non-perfusion of the choroidal and optic nerve circulations can also be detected, as seen here in this fluorescent angiogram corresponding to this red-free photograph. When we compare these two angiograms, we see that in isolated CLRDO, the underlying choroidal circulation is intact, which is not so in CLRDO associated with acute ischemic optic neuropathy. OCT shows paracentral acute middle maculopathy in eyes with isolated CLRDO or in eyes with CLRDO associated with CRVO, indicating incomplete occlusion of the cilioretinal artery. But in eyes with CLRDO associated with arteritic acute ischemic optic neuropathy, OCT shows hyperreflectivity of both the inner and middle layers of the retina, indicating complete occlusion of the cilioretinal artery. Typical visual field defect in an eye with isolated CLRDO is a secocentral scotoma, and less commonly, central scotoma or a central altiretinal defect may be detected in eyes with isolated CLRDO. As in patients with central retinal artery occlusion, giant cell arteritis needs to be ruled out in patients with cilioretinal artery occlusion, even if arteritic acute ischemic optic neuropathy is not detected clinically in these eyes. And for eyes with CLRDO associated with CRVO, systemic workup is as for CRVO, which we have discussed in the session on CRVO. If giant cell arteritis is detected or suspected in a patient with cilioretinal artery occlusion, urgent institution of intravenous corticosteroid therapy is mandatory to save the fellow eye. And if any other underlying etiology is detected as a potential cause for the CLRDO, it should be treated. Combined arterial and venous obstruction is a rare entity in which central retinal vein occlusion can be associated with either central retinal artery occlusion or branch retinal artery occlusion. We should note here that central retinal vein occlusion associated with cilioretinal artery occlusion is not considered as a combined arterial and venous occlusion. The risk factors of combined CRVO with retinal artery occlusion include hypercoagulable and hyperviscosity disorders, inflammatory disorders, compressive and infiltrative disorders of the optic nerve such as orbital mucormycosis, and trauma to the optic nerve such as from retrobulbar injections. Rarely, CRVO itself may cause a CRAO due to either increased hydrostatic pressure in the retinal venous system or due to an engorged central retinal vein compressing and occluding the central retinal artery lying beside it behind the lamina cribrosa. This is the fundus photograph of a patient with combined central retinal vein occlusion and central retinal arterial occlusion following COVID-19 vaccination. We note here that embolism is not amongst the causes because an embolism cannot cause a CRVO. Patient with combined occlusions present with sudden and severe loss of vision, usually in the hand motions range. In the acute stage, we will find retinal pallor and cherry spot as evidence of a central retinal arterial occlusion and dilated and tortuous retinal veins and retinal hemorrhages in all four quadrants of the retina as evidence of a coexisting CRVO. Marked thickening of the retina can also occur in an eye with combined occlusion. Over time, the optic disc becomes pale, the retinal arteries become severely attenuated, and neovascularization of the iris may develop in a very high proportion of these patients and quite early in the course of the disease and may progress to neovascular glaucoma. Needless to say, visual outcome is very poor in the majority of these patients. Fluorescent angiography shows delayed filling of retinal circulation and extensive areas of severe retinal capillary non-perfusion with sudden termination of the flow of dye at the level of mid-sized vessels and pruning or absence of capillaries. Disc leakage occurs secondary to the CRVO component as seen here in this fluorescent angiogram, but macular leakage is minimal. And as seen here in this OCT image, OCT shows hyperreflectivity of the inner and middle retinal layers as well as macular edema. Ophthalmic artery occlusion is a very rare entity, and since both the central retinal artery and the posterior ciliary arteries arise from the ophthalmic artery occlusion affects all retinal layers as well as the choroid, as both the retinal and choroidal circulations are compromised in ophthalmic artery occlusion. The clinical signs of ophthalmic artery occlusion can be either from a single obstruction within the ophthalmic artery or simultaneous occlusion of the central retinal artery and the ciliary arteries. Risk factors of ophthalmic artery occlusion include embolization, particularly injection of dermal fillers for facial rejuvenation in the brow and the periocular areas, and when these dermal fillers are inadvertently injected intraarterially, they may migrate in a retrograde fashion and reach the ophthalmic artery through communicating channels. Orbital mucormycosis, carotid artery dissection, retrobulbar injections, and orbital trauma can also cause ophthalmic artery occlusion. Giant cell arteritis is a rare cause of ophthalmic artery occlusion, but then ophthalmic artery occlusion is associated with arteritic anterior ischemic optic neuropathy. In contrast to central retinal artery occlusion, ophthalmic artery occlusion presents with light perception to no light perception vision, very intense retinal whitening extending beyond the posterior pole as seen here in this clinical photograph, and absence of a prominent cherry spot. And pigmentary changes in the retinal pigment epithelium become evident following resolution of the retinal edema. And all these clinical signs which are absent in central retinal artery occlusion occur in ophthalmic artery occlusion, because in ophthalmic artery occlusion, blood circulation to the choroid is affected in addition to blood circulation to the retina. Also, in contrast to central retinal artery occlusion, fluorescent angiography in ophthalmic artery occlusion shows non-perfusion of both the retinal and the choroidal circulations. and dark adapted electroretinography with a bright flash stimulus shows absence of both the negative A waves and the positive B waves, because both the outer layer and the inner layer of the retina are affected in ophthalmic artery occlusion. Ocular treatment has been found to be of no benefit, and visual prognosis is very poor in eyes with ophthalmic artery occlusion, but if any underlying etiology is detected, it should be treated. Cotton wool spots, as seen here in this clinical photograph, occur due to localized ischemia of the nerve fiber layer due to occlusion of either the superficial retinal capillary plexus or the radial peripapillary capillary network around the optic disc. Cotton wool spots appear as soft, fluffy white exudates in the superficial retina, rarely exceeding 1/3 of the size of the optic disc. Cotton wool spots are most commonly seen in the peripapillary region, and they do not occur in the foveal center where the retinal nerve fiber layer is absent. And on histopathology, areas of cotton wool spot show swelling of the nerve fiber layer and appearance of cytoid bodies, which occurs due to exoplasmic stasis subsequent to ischemia of the retinal nerve fiber layer. Cotton wool spots typically disappear within 6 to 12 weeks, and following disappearance, a shallow depression on the inner retinal surface may be detected at the site of a previous cotton wool spot. In the region of cotton wool spot, OCT shows hyperreflectivity of the inner retinal layer, particularly the nerve fiber layer, as seen here in this OCT image. This clinical photograph shows a lesion which is partly cotton wool spot in its inferior portion and partly paracentral acute middle maculopathy in its superior portion. And this OCT image has been taken with the scan line passing through the inferior portion of this lesion. Etiology of cotton wool spots is important, and diabetes and hypertension are the most common causes of cotton wool spots. Signs of diabetic and hypertensive retinopathy are usually found in eyes having cotton wool spots, but presence of a single cotton wool spot in an otherwise normal fundus, particularly if the patient does not have diabetes or hypertension, is an indication for systemic workup for other etiologies, which we'll discuss, and this is very important to remember. And an underlying etiology can be found in the majority of patients with cotton wool spots. And as with diabetes and hypertension, associated ocular and systemic features along with the cotton wool spot can often point towards the etiology of the cotton wool spot. Other etiologies of cotton wool spots are as follows, and they are mostly the same as the etiologies of retinal arterial occlusions, and they include ischemic causes such as radiation retinopathy, severe anemia, hypercoagulable and hyperviscosity disorders, severe acute blood loss, and in eyes with CRVO, BRVO, CRAO, BRAO, and ocular ischemic syndrome. Cotton wool spots can occur due to an embolus arising from a carotid source or a cardiac source, or from deep vein thrombosis if there is a cardiac septal defect, as well as from other sources such as drug abuse, long bone fracture, acute pancreatitis, and chest compression. Systemic inflammations can cause cotton wool spots, and we have mentioned these inflammatory etiologies earlier in this session. Systemic infections can cause cotton wool spot, among which HIV is important to remember, and cotton wool spot can also occur from bacteremia such as from infective endocarditis, fungemia, and systemic infections caused by Bartonella rickettsia and Leptospira, which are known to cause ocular inflammation with retinal vascular involvement. Interferon therapy can also cause cotton wool spots, and leukemia, lymphoma, and metastasis are neoplastic conditions which may cause cotton wool spots. Other causes of cotton wool spots include trauma, epiretinal membrane, high altitude retinopathy, papilledema, and papillitis. Paracentral acute middle maculopathy, or PAMM, was originally described as an SDOCT feature of hyperreflectivity of the middle retinal layer, as seen here in this OCT image, while sparing the inner and the outer retinal layers. We have just described this lesion in this color photograph, and this OCT image has been taken with a scan line passing through the superior portion of this lesion. PAMM occurs due to occlusion of the deep retinal capillary plexus, resulting in the ischemia of the inner nuclear layer, with the inner nuclear layer constituting the middle retinal layer on OCT imaging. So this is the normal appearance of the middle retinal layer or the inner nuclear layer, and this appearance of PAM occurs when this layer becomes ischemic. In contrast, cotton wool spots, which we have just described, occurs due to occlusion of the superficial retinal capillary plexus, resulting in ischemia of the nerve fiber layer. And patients with PAMM complain of sudden onset of paracentral scotoma or diminished central visual acuity. Clinically, in contrast to cotton wool spot, PAMM lesions appear deeper, grayer, smoother, more distinct, more translucent, and usually perivenular, because the perivenular location is the farthest from the arteriolar end of the capillaries. The PAMM lesions are evanescent and may disappear before clinical examination takes place, though hyperreflectivity on OCT may persist and be detected. After an episode of PAMM, as seen here in this OCT image, thinning of the affected areas of the middle retinal layers occur over time, as seen here in this OCT image, and visual defect persists. PAMM typically occurs with incomplete occlusion in the retinal circulation, and with more severe degrees of occlusion, the inner retinal layer also appears hyperreflective in addition to the middle retinal layer, and or the PAMM lesions become more diffuse and do not remain restricted to the perivenular location. And this progression from the middle retinal layer to the inner retinal layer and from the perivenular location to elsewhere is called the ischemic cascade, which may be demonstrated in an eye over hours to days. Workup in patients with PAMM is similar to workup for cotton wool spots and other forms of retinal artery occlusions. Differential diagnosis of retinal arterial occlusions include Cilioretinal, also called Berlin's edema, which occurs following blunt ocular trauma, retinitis, Takayasu arteritis, which occludes the major thoracic blood vessels, metabolic disorders which cause cherry-red spot, and retinal astrocytoma, which is a white-colored tumor. To recap the salient points, central retinal artery occlusion, or CRAO, usually occurs due to a thrombus occluding the central retinal artery at or just posterior to the lamina cribrosa. CRAO has been classified as non-arteritic and arteritic, with arteritic contributing to 5% of all CRAOs, most commonly due to giant cell arteritis. Systemic risk factors for CRAO include hypertension, diabetes, hyperlipidemia, cigarette smoking, cardiac valvular diseases, myocardial infarction, inflammatory diseases such as giant cell arteritis, and coagulopathies. Ocular risk factors include acute elevation of intraocular pressure, as may occur after intravitreal injection of expansile gases, and prolonged compression of the eyes. Patients with CRAO complain of sudden onset severe visual loss, which may be preceded by transient visual obscurations. Visual acuity ranges from counting fingers to light perception, but is rarely no light perception. Patients with foveal sparing by cilioretinal artery have preserved central vision with surrounding visual field defect. On examination during the acute stage, RAPT can be elicited, and the characteristic findings on fundus examination are retinal pallor in the posterior pole with a cherry red spot at the foveal center. In patients with foveal sparing by the cilioretinal artery, a portion of the macula has a normal appearance and is well demarcated from the surrounding pale retina. But in an eye with arteritic CRAO, even if a cilioretinal artery is present, the cilioretinal artery gets occluded by the arteritic process, and cilioretinal sparing of the fovea doesn't occur. The retinal arteries appear thin with segmentation of the blood column, and emboli may be detected within them. The optic disc usually appears normal in non-arteritic CRAO, but in arteritic CRAO, it typically appears severely pale and edematous because it is usually associated with arteritic anterior ischemic optic neuropathy. The occlusion in the central retinal artery occlusion recanalizes within 3 days following onset of CRAO, and visual recovery, if any and infrequently to a useful level, occurs only within the first 7 days after the onset of CRAO. In the chronic stage, the retinal pallor and cherry red spot disappear, the optic disc appears pale, the arteries appear narrow and sheathed, and cilioretinal collaterals may be found around the optic disc. Neovascularization occurs in 20%, usually on the iris. Patients presenting with a recent onset CRO should ideally be managed in a stroke unit to monitor for and manage cardiovascular and cerebrovascular events which have a higher risk of occurring immediately following a CRO, and management in a stroke unit takes precedence over ocular diagnostic evaluations. Fluorescein angiography shows delayed filling of the retinal arteries and veins, preserved cilioretinal circulation in eyes with foveal sparing by cilioretinal artery, and in arteritic CRO, choroidal and optic nerve circulation also show filling defects. Following recanalization, fluorescein angiography may appear normal, but the vision remains permanently impaired. In the acute stage, OCT shows diffuse hyperreflectivity and thickening of the inner and middle retinal layers, with hyporeflectivity of the outer retinal layer because of shadowing from the hyperreflective inner and middle retinal layers. In incomplete CRO, only the middle retinal layer is affected, and this is called paracentral acute middle maculopathy. In the chronic stage, the layers which appear thickened and hyperreflective in the acute stage become severely thin. ERG shows absence of B waves with preserved A waves in CRO, and this is called a negative ERG waveform. Systemic workup for patients with CRO includes evaluation for giant cell arteritis, carotid artery imaging, echocardiography, and testing for coagulopathies if suspected. Suspected or diagnosed giant cell arteritis should be immediately treated with intravenous steroids to save the fellow eye. There are no evidence-based ocular treatment for non-arteritic CRO, but several measures can be attempted and should be instituted as early as possible, ideally within hours following onset of symptoms. These include digital messaging, anterior chamber paracentesis, carbogen and hyperbaric oxygen therapy, vasodilators such as pentoxifylline, NDAG laser embolysis, and intraarterial tissue plasminogen activator. Ocular neovascularization, if it occurs, requires panretinal photocoagulation. Branch retinal artery occlusion occurs due to obstruction of a branch retinal artery, usually due to an embolus lodging at the bifurcation of a retinal artery. The risk factors of BRAO are similar to that of CRAO, except that BRAO rarely occurs from giant cell arteritis, and that BRAO can occur from certain inflammatory diseases, including Suzak syndrome. Patients with BRAO present with a sudden onset of sectoral visual field loss, and on examination, the affected retina appears pale. The causative embolus is detected at a retinal bifurcation in a majority of patients if examined early on. Cholesterol emboli appear yellow, spheroidal, and refractile. Platelet fibrin emboli appear dull gray and have an elongated appearance, and calcific emboli are larger and appear white and non-refractile. Cholesterol and platelet fibrin emboli usually arise from atheromatous plaques in the internal carotid artery, and calcific emboli arise from diseased cardiac valves. Clinical signs and diagnostic findings of BRAO are similar to that of CRAO, but localized to the affected retina. Systemic management is as for CRAO. Ocular treatment is not indicated for BRAO unless fovea is involved. Cilioretinal artery occlusion can be of three types: isolated CLRAO, CLRAO associated with CRVO, and CLRAO associated with AION. Isolated CLRAO has a good visual prognosis, but the latter two has guarded to poor visual prognosis depending on the severity of the associated entity, CRVO or AION. Clinical and diagnostic findings are that of retinal artery occlusion localized to the affected area of the retina, along with clinical and diagnostic findings of the associated entity, CRVO or AION. Combined CRVO and CRAO or BRAO is a rare entity whose risk factors include hypercoagulable disorders, inflammatory disorders, and compressive, infiltrative, or traumatic lesions of the optic nerve. Patient presents with a severe visual loss in hand motions range, and fundus examination shows feature of both CRVO and CRAO or BRAO. OCT shows hyperreflectivity of the inner retinal layers and macular edema. Visual prognosis is very poor. We should note here that cilioretinal artery occlusion associated with CRVO is not considered as a combined artery and vein occlusion. Ophthalmic artery occlusion is a rare entity whose risk factors are similar to combined occlusions, but in addition includes embolization, particularly from dermal fillets used for facial rejuvenation, and carotid dissection. Patient presents with severe visual loss, which can be no light perception. In contrast to central retinal artery occlusion, both retinal and choroidal circulations are compromised in ophthalmic artery occlusion, and thus clinical findings of ophthalmic artery occlusion include intense whitening of the retina extending beyond the posterior pole, absence of a prominent cherry red spot, non-perfusion of retinal and choroidal circulations on fluorescent angiography, absence of both A and B waves on electroretinography, and extensive RPE changes following resolution of retinal edema. Visual prognosis following ophthalmic artery occlusion is very poor. Cotton wool spots are localized infarcts of the nerve fiber layer which occur due to occlusion in the superficial retinal capillaries. They appear as soft, fluffy white exudates which disappear within 6 to 12 weeks. OCT shows thickening and hyperreflectivity of the inner retinal layers. Diabetes and hypertension are the most common causes of cotton wool spots. If even a single cotton wool spot is found in an otherwise normal fundus, particularly in patients without diabetes or hypertension, a systemic workup is required to detect any other etiology, which include ischemic, embolic, inflammatory, systemic, infectious, and neoplastic entities. Paracentral acute middle maculopathy was originally described as an SD-OCT feature of hyperreflectivity of the middle retinal layer representing the inner nuclear layer with sparing of the outer and the inner retinal layers. It occurs due to an occlusion in the deep retinal capillary plexus. It may be associated with the clinical finding of a retinal lesion which appears deeper, smoother, more well demarcated and translucent as compared to a cotton wool spot, and most commonly situated in a perivenular location. The lesion disappears within days to weeks, and following resolution, thinning of the affected zones of the middle retinal layer can be detected on OCT. Thank you for listening.